Hello, gang.
This is the gang. I've got a gang. Yes. Come on then, everyone.
Yes, let's proceed. We are going to do with part 2 of patient assessment. Welcome once again to Uncle Rob's Paramedic Playhouse. We are going to continue with this lecture in part 2. Try to move through it. I'd love to get this finished today, but I don't know that I'm going to. Got a meeting this afternoon. It'll probably be my day. Whatever I can get done, I'll try to today and get it up. It is a rainy October Friday. Come to think of it, I don't think I want to do patient assessment. It's close to Halloween. Let's spend the next hour or so telling ghost stories. I think that would be a lot more fun. No, I can't do that. We left off yesterday with assessing the airway. We had talked about assessing the level of responsiveness, but your text continued to say consciousness. I steadfastly maintain that those are two different things, really. Keep in mind what we're trying to do with the primary survey is determine a general assessment of vital systems, and that does include the CNS. I'll get into a more in-depth CNS as I continue to assess the patient later. Right now, I just want them to not die. And we're going to, having done the level of responsiveness, we're going to move to determining the airway status. You've heard me say this. This is not rocket science. This is pretty much common sense for anybody. Occluded airway is an immediate threat to life. If that's a surprise to you, please come and see me so we can talk. A patient who is alert and talking without signs of distress has a patent airway. They can be coughing, they can be talking, they can be doing a lot of things, but they're moving air. In the responsive patient, there are some things we can look for that while they may be moving air, you have evidence of an impending threat to the airway. Stridor. And stridor is a high pitch. This is an upper airway sound. And it usually denotes an airway that's up to 60% occluded, which is pretty significant. Stridor's worrisome, depending on the reason. If it's something we can quickly correct, which it may or may not be, I don't want to go down that rabbit hole. Difficulty speaking, and by that I mean they're not able to string long series of words together, sort of like me today. That could be a problem. Gasping, air hunger is another way of looking at that. They're trying to move air and unable to, or they're not speaking at all. If they're looking at me, they're reacting to me, and they're not speaking, I would just about bet you they're breathing. But let's don't take anything for granted right now. In the unresponsive or severely altered mental patient, mental status patient, well, I guess it would apply for mental patients as well if they fit into this category. Unconscious patients cannot maintain their own airway, or deeply unconscious patients cannot maintain their own airway. So there's a high risk of airway compromise, and you've got to take action to open and maintain the airway. If you'll recall back during our lecture in our lab on airway maintenance, one of our key concepts, there's that word again that I keep coming back to, concepts sometimes even over the dance steps that we teach you, the step-by-step pro forma way of doing things. If we forget the concept, then we generally tend to forget the steps because we don't know why we're doing them. But we talked about we have to aggressively not only attack that airway, but maintain that airway. That is our home base, is that airway. We want to make sure we open it and we keep it open. Talked about this. Again, this is a review for a medical patient. We use the head tilt chin lift maneuver. We don't hyperextend the neck. Please keep that in mind. We move it into a neutral position, basically, maybe a bit back. This actually helps lift the tongue away from the back of the throat. And I've had patients who are having really noisy upper airway respirations, snoring type respirations, and all we did was open the airway and magically it disappeared. We have some techniques to open the airway. There's manual airway maneuvers, suction or finger sweeps. Remember that I also told you to be very careful about putting anything in a patient's mouth that you want to get back, especially if their consciousness is altered in some way. just be careful. And then airway adjuncts, which we spent quite a bit of time talking about and playing with. Abdominal thrust, if we have to dislodge something. Let me go back to finger sweeps for a minute, guys. You really, if you see something in the airway, go get it if you see it. But I wouldn't go digging for it. For safety reasons, for one thing, and you may make a bad situation worse if you go in there and induce vomiting in an unconscious patient. We've automatically got a potential for an airway compromise. That will bring me back to abdominal thrust. We were trying to dislodge something that is occluding our airway. And then, of course, positioning. There's a lot of ways we can address this problem, some of them more aggressive than others. Let's talk for a moment about some indications of a partial airway obstruction. I mentioned snoring respirations a couple slides back. The tongue is usually the culprit in that. The tongue is in the airway, and it's causing a partial occlusion. Manual maneuvers and airway adjuncts, the oropharyngeal airway, nasopharyngeal airway. We've played a lot with these. We've talked a lot about these, about when to use them, when not to use them. These will usually take care of the tongue. And as you recall, the tongue is the most common airway obstruction. Let's talk a little bit about some sounds that may indicate a partial airway obstruction. Snoring, or sonorous, which is a word that I once knew and just realized until I read it that I'd forgotten it, but it sounds very medically, and we like medically sounding words. So snoring, we all know. I don't think I have to describe that for you. Again, the tongue is probably your culprit. Gurgling, I don't really think I have to describe this one either. This is usually, it can be a lower airway sound, but in the context we're talking about now, it's probably better to refer to it as accumulation of fluids in the upper airway, emesis, which is another medically sounding word for puke, or just fluids of some type that are in the upper airway. Suctioning, generally will take care of that one for you. Crowing is weird. It is harder to describe. Your text here describes it as a sound like a cawing crow on inspiration. Narrowing of the airways, generally what causes crowing. It comes from a whole lot of different things. The stridor, which we've already discussed, which is a harsh, high-pitched sound, most pronounced on inspiration. And that is a hint that you've got a at least partially occluded airway, maybe substantially occluded airway. Still moving air, but it's against resistance because the airway is partially blocked. Indications of a partial airway obstruction: gurgling, which I just said, as usual. I've gotten ahead of my slides. Suctioning and positioning will take care of gurgling. And if you've got gurgling, I don't want to force us down a rabbit hole, but I should say it. You are looking at a potential further problem that at this point in your education I don't want you worried too much about, but it is something that it would flag me on, is that if I've got gurgling, I've got fluids in the airway, there's a good chance I've got fluids in the lungs, possibly. You got aspiration pneumonia of some type. Remember, these patients may not be maintaining their airway very well. There's not a whole lot other than the epiglottis, and if they're deeply unconscious, that may not be faulty, may not be working. But suctioning and positioning of the patient usually takes care of that. Crowing and stridor. These are those high-pitched, predominantly inspiratory sounds that indicate swelling or muscle spasms of the airway. As a rule, manual maneuvers don't relieve these obstructions. Do not insert anything in the airway of a pediatric patient with crowing or stridor, because you may be looking at a case of epiglottitis where the epiglottis is swollen and extremely annoyed and may decide to clamp down in a laryngospasm. scary situation, which we will talk more about when we get into pediatric patients. After opening the airway, we're going to assess whether the breathing is adequate or inadequate. If it's adequate, we take that into account along with other factors, such as the patient's appearance, for one, to determine the need for oxygen therapy. Remember, we're doing a survival scan, and we're primarily looking for what is killing my patient right now or stands to. So we really do, I got to be careful of what I say here because I don't want to confuse you. As a matter of fact, I won't say it. Let's just leave it alone. Determine whether the breathing is adequate or inadequate. This is a quick decision that you're going to make. Most of the decisions you make during a primary survey they're yes/no questions. Yes, there's a few maybes in there, I won't lie. But are they breathing adequately or are they not breathing adequately? We're not worried about the why right now, unless it is an airway obstruction, which we should have already cleared. But we're doing a really quick survival scan now. Are they breathing adequately or not breathing adequately? And this doesn't take that long to figure out. This only takes a few seconds to make that call. If they're not, oxygenate, and I'll leave that alone. Positive pressure ventilation with supplemental oxygen for adequate breathing. We've talked about this in class as well, in our airway and O2 therapy class. A lot in that statement, that one little bullet at the end, because we have a range of devices and a variable set of circumstances. So which one you use to accomplish this will depend on what you think the patient needs. If they're not breathing at all, it's an easy one. You're going to bag them. If they're breathing, you're going to select an O2 delivery device. They need supplemental oxygen, and I'm going to leave that one alone, or I'm going to end up reteaching that entire unit. And your chart here: inadequate or inadequate tidal volume equals inadequate breathing. Inadequate rate or inadequate tidal volume. Inadequate breathing. Pretty simple. That's what I was trying to say in the last slide. I've got to stop getting ahead of my slides. Inadequate breathing rate, inadequate rate, and inadequate tidal volume equals inadequate breathing. My coffee's not kicked in. Adequate rate and adequate tidal volume equals adequate breathing. That statement just went right under my head. It's self-evident. And at this point, we want self-evident. We want, are they breathing well or are they not breathing well in our primary assessment. Assess rate and quality of breathing. Look for the following: inadequate tidal volume, abnormal respiratory rate, bradypnea, tachypnea. These things are usually noticeable, even when you're trying. Even if for some reason you were trying not to notice them, they're very hard to not notice. They're there. Assessing breathing. If breathing is inadequate, administer oxygen if indicated. That's a weirdly worded statement. If breathing is adequate, administer oxygen if indicated. Okay. If breathing is inadequate, begin positive pressure ventilations with supplemental oxygen. I could pick at that, and I might have to a little bit. To me, the positive pressure part kind of throws me a little bit. Positive pressure will be indicated if their respiratory rate were completely ineffective. If it's tachypnea, bradypnea, supplemental oxygen may solve your problem rather than going straight to positive pressure ventilation. But hey, let's not quibble. Assess rate and quality of breathing. We have our God-given tools of eyes and ears and the sense of touch, tactile sensation. And we're going to start with look. What are we looking for? We're looking for retractions. We talked about those and what they mean. The use of accessory muscles or nasal flaring, tracheal tugging, pale, cool, clammy skin. Remember what we said about stressors in the body and the body's response to a stressor, meaning the release of catecholamines. So if they're not breathing, their body's stressed, and those mechanisms have been activated, and that's where our pale, cool, and clammy skin may come from. Cyanosis, which is, of course, blueness around of the skin, around the lips, and the mucous membranes. As I said when we talked about pulse oximetry, anything below 94 is at least worth a cocked eyebrow. How about that? And the reason I say that, and I should be keeping this very clean for you, but I know patients with chronic respiratory problems where 94% is a great day for them. It's a great day for them. We talked a lot about this when we were talking about oxygenating therapy, and we talked about patients with chronic respiratory illnesses typically have pulse oximetry readings below 94%. But 94% or lower, 94% would give me a moment of pause, at least to make note of that and think that, because at this point, remember, we haven't taken the patient's history. I don't know for sure. I may know by looking if they've got a chronic respiratory problem. But at this point, nobody's told me that. So, yeah, 94% would get my attention. Asymmetrical chest wall movement, which usually denotes something mechanically wrong with the parts of the respiratory system, or the thorax, which is a big pressure chamber, which we need it to be. Let's use our other tools assessing rate and quality of breathing. Listen and feel. Listen for air movement and feel for the escape of warm, humidified air. And your breath. If you've ever breathed on a mirror, you know where that's what comes out, warm, humidified air. Absence or inadequate breathing. No chest wall movement or sensation of air moving would tell you, I've got really crappy respirations here, or I have no respirations here. Inadequate breathing, insufficient rate, tidal volume, oxygenation, or other signs of respiratory distress. And I'm going to leave it alone. I was going to say something there, but I'm going to leave it alone. Adequate breathing. If the chest is rising and falling adequately, and you hear and feel good air exchange, the respiratory rate is adequate. And there is no evidence of serious respiratory stress, assume that the patient's breathing is adequate. Like everything, guys, making judgment calls about adequacy and inadequacy, it gets a lot easier the more you do it. The more you do it. I'll just say that. Assessing oxygenation. We're looking for hypoxia or hypoxemia, which is, hypoxemia, of course, is low oxygen content in the blood. Remember, we talked about a VQ mismatch. We talked about some things that can cause hypoxemia, even if the respiratory system is working. We didn't go as deep in it as we will, but we did talk about it. Poor perfusion, heart failure, respiratory distress. Poor perfusion, we could take the rest of the day talking about the potential causes for poor perfusion. Heart failure, that in and of itself is a specific problem, scary problem too. It can be, especially at the EMT level, and we'll discuss that more when we get there. Yeah, we're not going to do this. We're not clicking on the item below. Primary assessment of circulation. During the primary assessment, we are assessing for the presence or the absence of a pulse. We are also assessing for possible major bleeding And then we wanted just a general impression, skin color, temperature, and condition. No, you're not going to pull out your thermometer here necessarily. We use relative skin temperature for this. Cool, hot, normal, doesn't feel either one. And we can assess capillary refill, keeping in mind that there are things that can affect both your pulse ox and your capillary refill, such as cold temperatures, cold ambient temperatures, the shock response being initiated, even in the early stages. Assess pulses. If there's no radial pulse, palpate the carotid pulse. You don't have either, start counting taters on that chest, because you've got a CPR situation going on here now, probably. It is, I don't like to use the word impossible in anything related to medicine, because there's always weird cases out there. But it is nearly, I'd be willing to bet, if I was sure of this, as I was sure of winning the lottery, I would probably be out, picking out my yacht. You're not going to have respirations without pulses. You might have pulses without respirations, but it is very, very rare that anybody's trying to breathe when they don't have a pulse. There may be some agonal activity going on there, but no pulse. You got this far in your primary assessment, and you got no pulses, you're looking at a CPR situation. We use brachial pulses in babies less than 1 year. There was probably a time in my life I knew why, but maybe just because it's the easiest one to get to. Babies have very small vessels, and the brachial artery is a rather large vessel that we can actually get to with our big fingers, in contrast to that little bitty tiny arm. Just looking at that looks like a very healthy baby. Probably a little annoyed with this person poking her in the arm and taking pictures. Quickly determine, when you're assessing the pulse, if the pulse is present or not. Yeah, that's kind of important. The approximate heart rate, beats per minute, pulse's regularity and strength. I'm tempted to pontificate upon the second bullet in that, but I'm not going to at this point. We are still in a primary assessment, and I'm not probably going to. I'll tell you this. Let's take off our student hat and put on our reality hat. I'm probably more interested in a relative heartbeat. Does it feel fast? Does it feel slow? I'm not probably concerned so much about the exact beats per minute at this point. Vital signs comes in the secondary survey, and I'll get it then. I really, honestly, if I'm being honest with you, when I go out and I'm doing this, when I check that pulse, when I'm doing my version of the survival sweep, I'm checking to see, does it feel fast? Does it feel slow? Is it faint? Is it strong? I'll get the particulars in just a bit, assuming he's got one, because if he's got one, then I'm looking at a CPR situation most likely. Other than that, I think it's good information there. Identify major bleeding. If you notice large pools of blood or blood-soaked clothing, immediately expose the area. You need to find it. You need to find out where it's coming from. Bright red spurting blood is arterial. Dark red, steady, rapid bleeding is venous blood, or coming from the veins. Remember, we talked about this. The arterial blood is under pressure. So is venous blood, just not nearly as much. And also remember, too, and this is why I like to do the sweep, because blood will cling to clothing. It'll pool sometimes under the patient. You're not even really aware of it until you go to move them, and then you find it. I've had that happen. Didn't see a drop, didn't appear to be any, but yeah, they were bleeding, and they were bleeding underneath themselves, and it was being hidden by their own body and by their clothing. back at our scaffold friend again from part 1, and we are checking for major bleeding. She is doing the sweep, and again, there's our dude over there at the head, thinking about what kind of pizza he's going to get when they finally finish up, because that's all he's got to do is hold that head at this point. We talked about this in class. We talked about trauma naked. We talked about what it meant. And that really does apply to multi-system trauma. A lot of times when I've got a patient who's busted up and I just don't know to what degree from a traumatic event, I'm going to probably expose all of them. Of course, I'm going to try to protect their privacy. I'm going to try to do this with some kind of dignity. But I got to see where they're bleeding from. And the easiest thing to do in a multi-system trauma situation is just strip them. Get all the clothing out of the way. If I see blood from a particular area, and that's what they're really showing in this picture here. You know, we had the leg wound, and we saw the blood, and she saw the blood, and now she's cutting the pants to expose it. So, you know, everybody who scrapes their knee doesn't get stripped. And if that's happening, then somebody's going to be investigated. But there are times you have to use your judgment. And if I've got what I think might be multi-system trauma, I got to examine my patient. I got to see where they might be hurt. Skin color, temperature, condition of the skin, assess capillary refill. And you notice she's pulled her glove back. This is one of those times where you've got to touch people. You have to put skin against their skin. And notice we're not talking, as I mentioned earlier, we're not talking about pulling out a thermometer. We're talking about relative skin temperature. Understand the limits of that. It also depends on environment. It also depends on you to a certain degree. If you're cold, if this is outside, or you were outside and you come in and your skin is cold, their skin's going to feel warm. So you have to use some common sense in this as well. And capillary refill, again, taking into account such factors as the environment, the patient's health. If they've got peripheral vascular disease, then capillary refill may be a little deceptive. It's one piece of a big puzzle, and that's what we're doing here, guys. We're putting a puzzle together of the general condition of our patient. Some good information here. Assessing perfusion, skin color, the mucous membranes. If you have a person of color, cyanosis, for example, might be a little more difficult to ascertain, but you can always go to the mucous membranes. They are universal. Look at the underneath the eyelid. Look at the gums. Look along those places, and you can observe the same thing in everybody. Pale or mottled, which means decreased perfusion and shock, as a rule. Cyanotic means decreased oxygenation. You need O2. Red, they're flushed, which is caused by vasodilation. And yellow is usually an indicator of liver function. It takes a while to develop, so if you've got a yellow patient, then they've probably had a problem for some time. It may not have been very long, but unless it's just a sudden liver failure, and the only time I've actually seen anything like that was when certain poisonings where their liver just shut down, and it was, hours, even days in some cases, and they had already started turning yellow. Skin temperature, hot means it's a hot environment or an elevated temperature. Cool is a cold environment or decreased perfusion. Cold, frostbite or hypothermia, and we're going to talk about that in environmental emergencies. We're going to talk about the specific ways that we deal with these problems, and there are some very specific ways we deal with them. Cool and clammy means shock, nervousness, fright, a stressor on the body. And it can be a psychological stressor. I broke out in a cold sweat before from certain stressors. It had nothing to do physically. It was an emotional stressor. Skin condition, if it's dry, dehydration, heat stroke, spinal shock, medical conditions, or they don't moisturize, or they're normal. These illnesses, dehydration, heat stroke, spinal shock, medical conditions, are a different kind of dry. Right now my skin is dry. It's not overly dry, but it's dry because I'm not wet, even though it's raining today. Moist environment, exertion, shock, and medical conditions may cause moist skin. We've got more of these, but before I go further, I'm just going to say this, guys. The more you examine people, the more real-life encounters with people, different people, that you have, the better you will understand this. It will make so much more sense than it does now. We're going to talk about all of those conditions up there under dry, and we have talked about some of them to a certain degree, but we're going to talk about them in detail, and I'll move on from there. Capillary refill is more reliable in infants and children for reasons that I mentioned a few slides back. It's more reliable at room temperature for reasons I mentioned a few slides back. And alone does not provide an accurate determination of perfusion status. It is one piece of a much bigger puzzle that we have to deal with. That would be a slide that tells us that we're going to look at some skill stuff. Cap refilling kids, and you can press your thumb down on the kneecap. I showed you a few of these in class, a few different ways of assessing capillary refill. And this is one. Count the number of seconds it takes for the color to return. When you press on the skin, it blanches out, and you want to count the seconds that it takes for it to return. And it should take no more than a couple of seconds in a normal environment, especially on a kid. The color should return very, very quickly. If it does not, in a kid particularly, I got to be careful. I'll drive us down a rabbit hole. If it doesn't in a kid, we may have some serious problems. Don't go there, Rob. I'm not going to go into hypovolemia in a child. That's a lecture for another day. We'll talk about that another day. Shock, hypoperfusion, is a life-threatening condition. Treatment needs to begin during the primary assessment, and I certainly agree, and we've talked about this. Everyone dies from shock, guys. No matter what you die from shock. Shock is really, they say it's a condition. Actually, it's a process. It is the body's attempt to maintain homeostasis. It's the body's way of combating whatever's messing up that homeostatic state, that same state. The body's trying to correct it. And it will continue to try until all of its defensive mechanisms are exhausted, and then we die. I'll leave it alone from there. I thought it was interesting. People say, and a lot of lay people, he's in shock, which implies there's an out of shock and in shock. And the fact of the matter is, shock is a process. It starts off, and in its early stages can be almost unnoticeable to the untrained eye, particularly, that someone is slipping into shock. What that really means is those compensatory mechanisms are already kicked in. They just hadn't went into high gear yet. We've not reached crisis stage yet. So we get early signs of it. And as whatever the problem is continues to not be corrected, the body tries harder and harder and harder to protect the brain, the heart, the lungs, to a lesser degree. Eventually it'll even sacrifice the kidneys. But it's trying to preserve those core organs and their perfusion status. Oh, I almost forgot about our case study. Let's see what we've got going on now. With the patient now supine, Carrie notices that Bob is snoring. He uses a jaw thrust maneuver to open. Remember, he fell off the ladder. A jaw thrust maneuver to open the airway, which relieves the snoring. Carey determines that Bob is breathing about 12 times per minute and that his chest is moving adequately with each breath. Carey can feel Bob's breath with each exhalation. And I need more coffee. Carey places an oropharyngeal airway to assist with airway control. Oh my. Okay. They're keeping it simple, so I will. I like the oropharyngeal airway, I really do, and I would be careful about sticking one in Bob's face because you only got 2 of them out there, and you've got a spinal injury. So if Bob pukes, then Carey's going to have to do a really quick log roll, and I hope they got their suction handy. Anyway, back to the program. Della reports a strong, regular rate of pulse and cool, moist skin. As Della searches for, let me stop. I just thought of something. My ADHD kicked in. You got to control that airway. You've got to stop the snoring respirations. You've got a partially occluded airway. You can't use a nasopharyngeal airway because Bob may have a head injury. So I'm not criticizing Carey for doing that. I'm just saying they kind of cavalierly threw that in there. But these are tactical decisions you have to make. You have to consider, well, I've got to open that airway up. Really, she didn't at the moment because according to the case study, when they did the jaw thrust, it stopped. It's kind of hard to hold a jaw thrust for a long period of time. But you at least had some time to play with it. I probably would have went on with my assessment before I addressed that snoring respirations as long as they were controlled. Now, I'm getting far, far into the case. That's what case studies are for, though. I'm doing what you should be thinking about, too, picturing this in your head and how it will play out. So I'm not criticizing. I'm just saying, I think if I'd opened that airway and the jaw thrust momentarily, we had the C-spine managed and the airway open with a jaw thrust, I probably would have proceeded with my primary survey and came back to a more permanent solution for that airway. When I had time to consider whether this move is going to complicate my existence by making this guy puke like a fountain when I stick it in. Anyway, that's just me. And we're back. As Della searches for any obvious bleeding, the paramedic assigned to the call arrives. He obtains a quick report from Carey. Oh, we got the medic there. Okay. He obtains a quick report from Carey, asks Bob's sister a few questions, and prepares to obtain Bob's blood glucose level, which I would think is a very appropriate step to take. Things are doing okay. Bob is appears to be holding his own well with his vitals. They've got the airway managed. We're going to move into trying to get a little deeper into what might be wrong with Bob. What factors should the crew consider in determining whether they should perform a quick secondary assessment and prepare for immediate transport, or do a more thorough assessment and initiate treatment on the scene? This is actually a good question, and this is a decision that we make. Now, the medic's probably going to make it, but what he or she is going to consider, a lot of it, to me, would depend on that blood glucose. It comes down to a very simple factor for me. If the blood glucose is not the problem, if it's not the culprit that caused the fall, then I've got possible neurological damage. And even as a paramedic, I can definitively secure the airway. I can start IVs and I can do this, that, and the other. But if he's got his noodle scrambled, I can't fix that. So even for me as a medic, this would be not necessarily, oh my God, we're on fire, load and go, but it would be, we need to expedite this. We need to expedite this very, very quickly. Personally, I think probably what I would do is do enough of I'd get him in my bus for sure. And then I would certainly be curious as to what else might be wrong. But if I really think I've got a neurological problem, then we're going to expedite. The longer we wait, the more damage is being done, and I can't fix it. And until the day that they put a, inflatable surgeon in one of our side compartments, I don't see us being able to fix it. So the load and go question. And what did I tell you in class? I told you that any deficiency in the primary survey that you can't readily fix bumps us up to load and go. So if we want to keep it simple, a lot of it depends on the blood glucose. This is blood glucose. I can fix the neurologic problem most likely. That doesn't mean there couldn't be others. Doesn't mean that the blood sugar is going to make this guy whole. He could have busted his noggin when he hit the ground too. So we could have both. I hope I don't suspect that, because, well, I'm going to get into a lecture on D50 and possible brain bleeds. It's a little controversial. We don't really worry about it all that much, but we probably should. It's going to depend on that blood sugar as to what I do. If I can fix the neurogenic problem, everything else we've got under control for right now, so I'm not worried. I can go ahead and do a complete survey on the scene if the D50s, if the dextrose is the problem. Glucose is the problem. Dextrose is the solution. If you haven't noticed, guys, that I'm struggling, I haven't finished my coffee. It's rainy. I'm very proud of myself for just getting out of bed and getting here this morning. And I'm fully dressed, and I got here, so forgive me. I'm struggling a little bit this morning. I haven't had enough coffee, and I'm having to think. In the primary assessment, identify and manage life-threatening conditions immediately. This is redundant. We've talked about it, but it is very true. Any critical finding of the airway, breathing, oxygenation, or circulation categorizes the patient as unstable. Again, redundant. Anything I find in that primary survey that I cannot readily correct and understand, that could be a breathing problem that I, at the EMT level, can't do anything about. I can give him oxygen. I can maybe make it a little easier, and I can oxygenate him a little bit better, but I can't fix the underlying problem. So if I find it in the primary survey and it's bad and I can't immediately fix it or ultimately correct it, it's time to go. That patient is unstable. Once we have determined that a patient is unstable, it's time to expedite. It's time to move and get them out of there. There's nothing wrong with that, guys. You're going to run into situations. Even once you progress on through to your paramedic, believe me, you're going to run into situations, a lot of neurologic situations I can't do a lot for, except recognize that I can't do a lot for them and recognize we need to move. We're going to talk a lot about that when we get there. There's just some things I can't fix. I hate to be grim, but Lord knows it's a day for it with the weather outside. Rule number 1 in medicine is patients die. And rule number 2 is nobody changes rule number 1 ultimately. There are some people, it's just their time to go, and no matter what we do, we're not going to reverse that. I don't think Bob's in that category, though. I think Bob's going to be okay. These case studies like a happy ending. Unstable patients receive a rapid secondary assessment and immediate transport. When I was talking about Bob earlier, I said, it's going to depend on that blood glucose. I'm still concerned. The EMTs did a great survey, and they corrected a lot of things, and so I'm reasonably sure that he's breathing. He's not bleeding to death. He's moving air. Truthfully, and this is going to sound bad and probably earn me the enmity and hate of many instructors all over the world, but the spinal injury, unless it's causing my patient's vitals to be really, really screwy and bad, doesn't scare me enough to drop everything and run with the patient. I worry about spinal injuries because of the devastating after effects of spinal injuries, for my patient. But as far as their immediate threat to me, as long as they're not screwing up my vitals, and as long as we're managing it properly, that's all we can do. You know, it's not going anywhere, but it's not hurting my patient either. So I would probably go ahead and continue with an assessment. I'm not going to, you know, he's got a spinal injury. Yes, that would bump him up in the priority for transport, but it wouldn't stop me from checking out my patient. I think the difference would be I'd probably be doing a lot of this checking out the patient on the way to the hospital. I'm just, you know, I don't want to give you the idea that, oh, once you find something wrong in the primary survey, you load and go it and you don't do anything else. No, and your text doesn't take that into account either. But in a real situation with this guy, yes, I might decide if the blood glucose is not the culprit for the unconsciousness, and a potential for a spinal injury. Yes, I might decide, let's go ahead and get them in the bus, but I'm going to continue working in transit. I'm going to continue looking for things in transit. You know, I'm not done just because they're in my ambulance. I've just got them off the scene and I'm moving them toward the hospital in deference to a problem that I may not be able to correct. So truthfully, the safest thing to do would be to do that. Boredom, again, assuming that glucose is not the problem. Boredom up and get them in the bus, and I'll do everything else en route. That's not one of your options in a lot of this, but that happens a lot in EMS. I'm not done. I'm just not going to sit on the scene and do it. Stable patients are assessed further and treated at the scene. Unstable patients receive a rapid secondary assessment and immediate transport with continued stabilization during transport. So if we classify Bob as unstable, okay, I mean, they're not contradicting me. They're just phrasing it another way. I'm going to look to make sure I don't have anything I immediately need to address before we haul butt, and then I'm going to load him up and continue everything en route. We're not done. We're just done there. Bob's blood glucose is low, making the crew suspect that his unresponsiveness could be related to a diabetic emergency, which the paramedic can treat at the scene. Yes, we can. The paramedic starts an IV and administers medication as Della performs a secondary assessment, and Carey continues inline spinal stabilization and airway management, and he's probably getting extremely bored now because he's been holding this guy's head since he got there pretty much. Della finds a deformity in Bob's right arm. Bob quickly responds to the medication. And because he has a deformity in his right arm, he's probably wishing about now that he didn't. Carey removes the oropharyngeal airway as Bob wakes up. With Bob now alert and oriented, the crew is able to stabilize his injuries on the scene and obtain a thorough history while repeating the secondary assessment. Turns out the glucose was the main culprit, and it sounds like Bob's busted a wing. So there's other treatment that will be rendered along the lines of pain management by the paramedic, and it doesn't look like they're going to find anything else. And we'll transport him to the hospital where he will recover, and they will all live happily ever after. We're going to start part 3, the secondary assessment. I need to see how long. We're about 40, I need my glasses, we're about 49 minutes in. It's a good place to break it up, and I think I will. I think I will stop here, and we'll start the next phase of this, part 3, in part 3 video. So I will see you then, gang.
I thought we might need a gang. Not really had a gang before. It's new.